Today we are starting off a new series of ECG discussions. First, we'll have some arrhythmias. One important wide QRS tachycardia will be discussed today. This ECG shows a wide QRS tachycardia. What is special about it? Please look at lead 2, 3 and AVF. You can see negative complexes in lead 2, lead 3 and AVF. That is left axis deviation of the QRS complexes. Next you look at V1. You can see an incomplete right bundle branch block pattern here. Here the QRS does not appear so wide as in other leads, probably because a part of the QRS is isoelectric. You can see here probably a little bit of QRS is isoelectric. That's why here it would appear like a narrow QRS tachycardia. Then no obvious P waves are seen to say whether it is a supraventricular rhythm or ventricular rhythm. But if you look carefully, there are some distortions seen. You can see one distortion here in the ascending limb of the T wave, which could be a dissociated P wave, but we will not be very sure about it. Then we look at this T wave. There is some peaking of the T wave. There could be a P wave there. If those are indeed true P waves, then that is one feature of AV dissociation. But we cannot be very sure about it. Anyway, a wide QRS tachycardia, until proved otherwise, is considered to be ventricular tachycardia. In this case, there are two specific features you have seen. One is left axis deviation, suggestive of left anterior hemiblock pattern. Second is a right bundle branch block pattern. So when you have these two together in a ventricular tachycardia, one specific entity is known as posterior fascicular tachycardia, also known as Bell-Hassen's tachycardia. Bell-Hassen's tachycardia has some features, that is QRS will be relatively narrow. In this lead it appears like that. Here also there is probably there. But overall I would not say that it is relatively narrow. It's a really wide QRS tachycardia only. Bell-Hassen's tachycardia is an important type of idiopathic fascicular tachycardia. The advantage is that it is responsive to verapamil, unlike the other ventricular tachycardias. Then there is also a chance that it can be ablated, because you can map the tachycardia using catheters introduced into the heart, and when you can localize the exact region where the tachycardia is originating, then radiofrequency catheter ablation can be done. It will be a total cure against recurrent tachycardia. That is Bell-Hassen's tachycardia. Sometimes a tachycardia originating from the scar of inferior wall infarction can also have this pattern. That is one of the differential diagnoses. This is an illustration of the division of the His bundle. From the AV node, the His bundle arises. It divides into right bundle branch and left bundle branch, which can further divide into two, anterior fascicle and a posterior fascicle. These are the ramification of the posterior fascicle. So a reentrant tachycardia originating like this in the region of the posterior fascicle is what we have discussed in the ECG, posterior fascicular tachycardia, which is an ablatable tachycardia. It is also an idiopathic variety of ventricular tachycardia.